How does exercise affect a diabetic? There are two scenarios. One, a type of patient who is well controlled with increased insulin in the body, adequate insulin in the body. There is a type of patient who is decompensated with decreased reserve of insulin in the body, either due to insulin deficiency or insulin resistance. In the patient who has got good insulin or insulin reserve in the beta cell, or there is insulin responsiveness, less of insulin resistance, there will be a peripheral increase in the glucose uptake because of insulin, there will be decrease in the hepatic glucose output, and there will be insulin absorption, and such a patient is the one who will go in for hypoglycemia. Suppose there is already decompensated patient with decreased insulin and decreased insulin sensitivity or resistance to the insulin, peripheral uptake of glucose is decreased, hepatic glucose output is always on the higher side, there is lipolysis going on, such a patient is more prone for hyperglycemia and ketonemia. So, a type of patient who is well controlled is the one who is more at risk for hypoglycemia. A patient who is decompensated, burnt out diabetes, he is at a risk for hyperglycemia and ketonemia. This is in relation to the exercise. So, if a patient of well controlled diabetic exercises, then he can develop hypoglycemia. A patient decompensated patient, if he does exercise, then he may not get hypoglycemia. On the contrary, there will be hyperglycemia. Hypoglycemia is a preventable condition. What are the strategies to prevent hypoglycemia, particularly in a diabetic? Aggressive HbA1c control should be attempted within the protocol, within the treatment protocol. That means we should not go beyond 7 HbA1c. Anything around 6 or 6.5 will endanger us to produce hypoglycemia in the patient. When we are using insulins, it is better we use analog insulins which are less prone for producing hypoglycemia compared to the conventional insulins. Patient education about hypoglycemia is a must. Every diabetic patient during the initial interactions after the diagnosis should be educated about the possible hypoglycemia, the hypoglycemic symptoms, how to counter them, and also how to monitor their blood glucose at home. Empowerment of the patient to increase or decrease the insulin dose depending upon the blood sugar level and depending upon the symptoms, empowering the patient to reduce the medication whenever there is exercise, whenever there is lack of food, whenever he is on fasting. These are important steps. Consistent and frequent consistent monitoring, that is monitoring at the same time or monitoring before and after food, at before bedtime, and also frequent use of self monitored blood glucose and keeping a record of them, of those readings, will help us in picking up a possible patient of hypoglycemia. Adjusting physical activity and food in a diabetic. A patient of diabetic should not have undue physical activity or excess food, or vice versa, less food and more physical activity, or less exercise, more food. Anything can produce a swing of hypo and hyperglycemia. So, adjusting the physical activity and food are essential components in preventing hypoglycemia. Individualized HbA1c goal. The HbA1c goal for patient A may be 7, and at that level he may not develop hypoglycemia. Another patient may develop hypoglycemia even when the HbA1c is 7.5. So, another patient may not develop hypoglycemia even if the HbA1c is 6.5. So, you have to individualize the HbA1c goals rather than saying, so okay, blanketly everyone must have HbA1c around 6.5 or 7. Flexible regimens of insulin and OHA. So, these regimens should be tailored in such a way they should be able to increase or decrease one or more components of their treatment rather than having fixed combinations. Correction of risk factors, which we have already seen in the previous slides. These are all the strategies by which we can prevent hypoglycemic episodes. Delayed onset hypoglycemia. This can occur following high intensity exercise, following extended duration of activity, may occur up to 24 hours after the episode, after the exercise or high intensity exercise or extended duration. Adjustments to food and insulin after the activity. Lower the basal insulin for 8 to 12 hours. Low glycemic index snack should be kept handy. Lower mealtime insulin boluses. All these can reduce delayed onset hypoglycemia.